Well, thank you so much. It's really great to be here. I really always appreciate the invitation and the opportunity to come and be here with you all. It's really important to go over the year in review and look at all the new data and how it's beginning to influence our practice. Things are always changing very rapidly. It's a really great time, new agents, and I get to talk about a couple of trials, one of which led to a recent FDA approval, and one that we hope will have an approval later this year. So we'll have new agents as well. So it's a pleasure to focus on metastatic HR-positive breast cancer. It's such a drag of a topic. You know, we really try to prevent metastatic breast cancer as much as we possibly can. Unfortunately, most of our patients will, if they're going to die of breast cancer, they're going to end up dying mostly of HR-positive metastatic breast cancer. So it's really important that we have a lot of tools in the toolbox until the day comes when we can really, truly either cure this or make this a chronic disease. So fortunately, there is a lot of activity in this space. So I'm going to start by summarizing kind of where we are right now, and I will come back to this slide at the end as well in the context of the data updates that I will share with you. So the landscape is changing, and in the first line setting, however, we really do have endocrine therapy with a CDK4/6 inhibitor. As I'll show you, there's almost no role for chemotherapy, first line metastatic. It's the very rare patient that will get endocrine therapy alone. She's usually very infirmed and not able to travel. So it really is a CDK4/6 inhibitor with endocrine therapy. Second line, we have a variety of options you can see in the royal blue there. So if someone has a PIK3CA mutation, right now, it's fulvestrant plus alpelisib, the oral PI3 kinase inhibitor. We'll look at those data. We'll look at the Capitello 291 because capivasertib, or Capi, will be coming our way later this year, and that will be a very welcome addition. If her breast cancer is not PIK3CA mutant, we could potentially change her. If she's been on palbociclib, we could change her to ribociclib per the MAINTAIN trial. It's a small phase 2, but we'll look at those data. Of course, we could use exemestane or endocrine therapy, a different endocrine agent with everolimus. That certainly is an option. And now we have FDA approval for the first oral SERD called elacestrant, and that's also an option. That's a single agent endocrine therapy, an oral selective estrogen receptor degrader, and we'll look at that data. And then we do have chemotherapy for the patient with very severe disease. And then over on the right, if someone has a germline BRCA mutation, we certainly could think about a PARP inhibitor. Rarely, patients have MSI high or high tumor mutation burden. We could think about pembrolizumab, the rare NTRK fusion. We have 2 NTRK inhibitors. HER2 mutations do arise under the selective pressure of endocrine therapy. We have neratinib, fulvestrant, trastuzumab if you have a HER2 or HER3 activating mutation. And now, if we find ESR1 mutation, we have elacestrant, and I know we'll hear from Lajos Puzdai. We'll hear about the clinical utility of ctDNA. First line for after endocrine therapy is no longer benefiting the patient. We have single agent chemotherapy because in the second line, we have our ADCs for HER2 low. We have trastuzumab deruxtecan, and for HER2 zero, we have sacituzumab. And so that's a pretty good flow. It's really in the second line, but we do have options where a lot of these have not been compared head to head. So we truly have options for patients in the second line. We'll go through those data. So let's start with a summary of survival in the first line setting with the CDK4/6 inhibitors. And in the red box, you can see the survival data. And I've highlighted in red the statistically significant true first line trials of CDK4/6 inhibitors with an aromatase inhibitor, except MONALEESA-3 is actually with fulvestrant in the first and second line. And those 3 are with ribociclib, 2 with an aromatase inhibitor, the MONALEESA-7 on the right with an LHRH agonist for the premenopausal patients, and then the MONALEESA-3 is with fulvestrant, and these are all highly statistically significant. Monarch 2 is there because it's a fulvestrant, mainly second-line trial, but there were some first-line patients who were recurring on adjuvant AI, and that is also positive for survival, mainly a second-line trial, but there were some first-line patients in there as well. Now, if you look at Monarch 3, that was updated at ESMO in an oral presentation, and this is an interim analysis for survival, and we see a hazard of 0.75, which is similar to the Mona Lisa trials, and you see the p-value of 0.03, but it's not statistically significant per the pre-specified boundaries in the statistical analysis plan. But later this year, we'll have the final survival data on Monarch 3. It's looking promising. You can see the delta there, 54 to 67 months. It's looking promising, but it's not statistically significant at this time. And then unfortunately, you know, as we've heard, the Paloma 2 over on the far left with palbociclib AI first line, unfortunately did not reach, it was a negative trial in terms of overall survival. And very recently, the NCCN has changed their guidelines so that the category 1 evidence is for ribociclib, first line with aromatase inhibitor based on the totality of these data. And then abema and palbociclib right now are category 2A in terms of first-line choice of CDK4/6 inhibitor with an aromatase inhibitor in the first-line setting. So that's kind of where we are today. And I think since the palbociclib data became negative in ASCO 2022, there's been less use of palbociclib and more use of ribociclib, and there also is some increasing use of abemaciclib as well. These are the data from Paloma 2. Why exactly this came negative when the PFS data for all the trials looks identical is really a bit of a mystery, to be honest with you, but these are the data as they are, a negative trial for overall survival. Now, we did see these new data from San Antonio this year called the Right Choice, a randomized phase 2 trial. Interesting trial done in parts of the world where they see a lot of de novo metastatic breast cancer in pre- and perimenopausal women. And they really tried to choose women with visceral crisis. And you can see in the box on the top right that 52% did have visceral crisis, 67% symptomatic visceral disease. These were ill women. These are patients, but their bilirubin had to be no more than 1.5-fold the upper limits of normal. So they weren't in flagrant liver failure, but they were a very heavily burdened group of patients. These are the patients where the control arm was combination chemotherapy. And so this was a taxane and a metabolite, gemcitabine, capecitabine, or capecitabine, vinorelbine. So combination chemotherapy, a physician's choice, was the control arm versus an LHRH agonist, aromatase inhibitor, and ribociclib. So it was letrozole or anastrozole with goserelin and full-dose ribociclib. And this was a study of 222 patients, and the primary endpoint was progression-free survival. You see the data in the bottom right. You see the hazard of 0.54, and there's a doubling in the median PFS. And then you can see the curves bottom left, where there's a big split in these curves. And there are patients in the first 6 months who are progressing, but they're progressing equally on both arms. There wasn't any hint that they were going to have a slight advantage with chemotherapy on getting on top of that disease where they might not with endocrine therapy. There was really no difference in these patients who were destined to progress early on, but there was a huge difference in median PFS. So this kind of really nailed it down for me, that except for patients with really going into liver failure, where we have to give a light dose of chemotherapy and salvage that liver, that we really should be utilizing CDK4/6 inhibitor, ribociclib, in these pre-perimenopausal women with an LHRH agonist and an aromatase inhibitor. So this is a very, very powerful head-to-head first-line comparison. So clearly, CDK4/6 inhibitors, first line. What about second line? Well, several mechanisms of resistance, and what I'm going to focus on is further use of CDK4/6 inhibitors, and I'm going to focus on the PI3 kinase pathway, because these are the sort of the practical options that we have. And then I am going to also focus on the estrogen receptor itself as a mechanism of resistance to CDK4/6 inhibitors, because these are all very practical for us as we choose what to do after CDK4/6 inhibitor progression. So let's refresh the memory on the MAINTAIN trial from ASCO this year from Kevin Kalinske, a randomized phase 2, 120 patients who were mainly progressing on palbociclib. There were 14 patients progressing on ribociclib, which I'll show you, but the majority were progressing on an AI plus palbociclib. And they were randomized to just switch endocrine therapy, and the vast majority switched to fulvestrant with placebo, or switch endocrine therapy. Again, the vast majority were fulvestrant plus ribociclib. So basically a palbo to ribo, even in spite of the fact that they're progressing on palbo, switched to a different CDK4/6 inhibitor, the ribociclib. And the median PFS about doubled from 2.7 months up to 5.3 months, and the hazard ratio 0.57. And you can see there's these patients in the beginning that basically progress, and so they're endocrine therapy refractory. But then for those that have some endocrine therapy sensitivity, the curves split, and we can see benefit. And this trial met its primary endpoint. It was statistically positive in favor of the CDK ribo after palbo. There's only a small percent, about 20% get out a year, so that's good, but it's a small percent. Down the bottom box, you see the clinical benefit rate went from 25% with fulvestrant basically to 43% with the ribociclib fulvestrant. Now, in the forest plot on the top right, look at where it says in the middle, prior ribociclib. Those are the 14 patients, because we're using more ribociclib first line, so what do? Do we just continue ribo? Was that looked at here in this trial? And you can see that the hazard there for continuing ribo is 0.5. So big confidence intervals, small numbers, but at least there's some data from MAINTAIN that if someone's progressing on AI ribo and you want to switch them to, you want to use the MAINTAIN data, that you could continue the ribo and just switch the endocrine therapy. And NCCN's recent guidelines has put this as a footnote, and it's really for palbo switching to ribo. They put this as a footnote to alert us to these data. So that's an option. We saw the PACE trial, which was palbo after palbo. So these patients were progressing mainly on palbociclib and an aromatase inhibitor, 220 patients, and they were three-way randomized to fulvestrant versus fulvestrant plus continuing palbo versus fulvestrant palbo plus the PD-L1 inhibitor avelumab. And you can see in the top right that the bottom two curves are the fulvestrant and the fulvestrant plus continuing palbo. So continuing the same CDK4/6 inhibitor did not benefit patients more than just switching to the fulvestrant alone. So palbo to palbo, no benefit. Palbo to ribo, benefit. But interestingly, you can see the top there, the avelumab did improve PFS. Again, this is a signal. This would have to be looked at in much larger trials, but it's really quite interesting that a PD-L1 inhibitor might be of benefit. But palbo to palbo would not be the optimal strategy based on the PACE trial. Okay. So what else in second line? We've got a PIK3CA mutation. We have found it in the primary breast cancer, or we found it in ctDNA. And the SOLAR-1 was for patients, only 6% had a prior CDK4/6 inhibitor. So they basically were naive to CDK4/6 inhibitors, progressing on an AI, randomized to fulvestrant placebo versus fulvestrant plus the oral PI3 kinase inhibitor, alpelisib. And we see a significant improvement in progression-free survival from 5.7 to 11 months. So a definite improvement. We can see no difference in survival over there on the right. And so, of course, this became a standard option for our patients with a hemoglobin A1C less than 6.5%. But, of course, everybody gets the CDK4/6 inhibitor first line. So what about the use of alpelisib second line upon progression on CDK4/6 in the PIK3CA mutant population? And we see in the red box Median PFS is in the 5.6 to 7.3 months. For patients, like 7.3 months is fulvestrant alpelisib when they're just now progressing on CDK4/6 plus AI. That's the most common scenario. The 5.7 months are patients progressing on CDK4/6 plus fulvestrant, getting letrozole plus alpelisib. So this is less than we saw in the SOLAR-1 with 11 months median PFS, but still is in the 6-7 month range from median PFS in that second-line setting. And that's not dissimilar. We just saw the maintain, where it was about 5.4 months, so a little bit less, but in the same ballpark. We're kind of sitting around 6 months, if you will, median PFS in that second line. Now let's take a look at the new data. Well, the faction was before, that was San Antonio. Well, that's published in Lancet Oncology, but I'm going to update you on the Capitello 291 on the next slide. But this is capivasertib, CAPI. This is the oral AKT inhibitor. It inhibits all the isoforms of AKT, 1, 2, and 3. AKT is downstream in the PI3 kinase pathway from PI3 kinase, and then mTOR is below that. This is a very, very important resistance pathway, as we're all very well aware. So in the randomized phase 2 faction trial, patients had not had prior CDK4/6 inhibitor, and they were randomized to fulvestrant versus fulvestrant plus capivasertib. And you can see in the Kaplan-Meier curves, the two on the left are PFS, and the pathway non-altered patients, pathway-altered patients are, the top is PFS and the bottom is overall survival. Pathway-altered is PIK3CA mutation, AKT mutation, or genomic loss of PTEN. And those activate the PI3 kinase pathway. And in the faction trial, you can see on the curves on the left, PFS on top, OS on the bottom, nice separation of these curves. On the right, the pathway non-altered, we don't see very much there in the randomized phase 2 in the pathway non-altered population. But then let's take a look at the phase 3 data, Capitello 291, and in this trial, 70% of patients were progressing on a CDK4/6 inhibitor plus an aromatase inhibitor. And there was a co-primary endpoint, all comers, regardless of PIK3CA, AKT, PTEN mutation status, and then a second co-primary endpoint of the pathway altered, AKT pathway altered. Again, activating mutation, PIK3CA, AKT, or genomic PTEN loss. About 40% of patients were altered. And the primary endpoint was progression-free survival, and these patients were randomized to fulvestrant with placebo or fulvestrant plus capivasertib. Capivasertib is oral, 400 milligrams twice a day, 4 days on and 3 days off. Why? And that's to allow for some recovery from toxicity, particularly diarrhea, which is the main toxicity. Patients get some while they're taking the CAPI, then it stops when they're off the CAPI. This, when you inhibit AKT as opposed to PI3 kinase, you get some modest hyperglycemia, but not major league. You get, so in this trial, you were allowed on study if you were up to 8% hemoglobin A1C. So patients could have a little less good glycemia control. And so the primary endpoint, as I said, was PFS, and that is the randomization there. 40% had any AKT pathway alteration. Of those, 75% of those were PIK3CA. So about 30% had a PIK3CA, 5% had an AKT activating mutation, which tends to be acquired, tends to be something you find upon progression on an AI, and the others, PTEN loss, which can be acquired, and I think can also be in the primary breast cancer. And so the primary endpoints are here. Up at the top is the overall population. Everybody, we see a statistically significant improvement in PFS. Top right, 3.6% with fulvestrant doubling to 7.2%. You know, this is in the ballpark of the BYLieve trial that I told you about with the PIK3CA mutations and the alpelisib after CDK4/6 inhibitor. Bottom left we see the altered population, the hazard of 0.5, 3.1 months going up to 7.3 months. So both all comers as well as the altered population, we see an improvement here. Down the bottom left, we see when you just look at those patients who are known to not have a mutation, okay? We see a hazard of 0.79, and that is still trending in the right direction. So there's a more modest, but still trending favorable impact in patients who are not known to have an alteration. And we can see in the bottom right, we can see almost a tripling of the response rate from around 10% up to almost 30% in patients adding the CAPI to fulvestrant in those who have an AKT pathway mutation. So this is quite a good level of anti-tumor activity. And I love the boxes in the forest plot. The bottom box is prior CDK4/6 inhibitor, 70% of patients versus not. You can see the point estimates are the same. And then above that is liver metastasis. That's a particularly difficult group of patients in our practice, and we can see hazards of around 0.5. That's really, really gratifying to see that level of activity. In terms of, you can see the survival or pending, overall survival on top, overall population versus AKT pathway altered on the bottom. Survival's trending in the right direction. We'll wait and see. And then safety on the right, only 18% of patients had any hyperglycemia, so it was really quite modest. Diarrhea, 72%, 9% had grade 3. But again, 4 days on, 3 days off, it's quite manageable because it isn't lasting very long, and then it goes away. Some rash as well. And I did want to mention in Solar 1 and by leave, there were data called the Metallica trial at San Antonio, giving prophylactic metformin, about 500 BID, before starting the alpelisib, and that's a strategy that I'm starting to use to try to decrease the hyperglycemia that happens with alpelisib. We have less hyperglycemia here with capivasertib, even going up to 8% on the hemoglobin A1C. And then the Emerald trial. This is elacestrant, which has just very recently become FDA approved. And this is the first oral SERD. And these patients had a prior CDK4/6 inhibitor, 1 or 2 lines of prior endocrine therapy in the metastatic setting. They could have had up to 1 prior chemotherapy, and they were randomized to oral elacestrant, 400 milligrams daily, versus mainly fulvestrant, but they already had fulvestrant. They could get an AI. And the primary endpoint was PFS in all patients versus in the ESR1 mutant population. And in all comers, as well as in the ESR1 mutant population, PFS was statistically in favor of elacestrant. And then we saw updated at San Antonio, this is all comers, that if the more endocrine therapy sensitive the breast cancer is, the more likely patients are going to benefit longer term with the elacestrant. And so the surrogate there is how long were they on the antecedent CDK4/6 inhibitor. So if they were on the prior CDK for 18 months in all comers, they had over 5 months median PFS on the right. But the FDA approved elacestrant in the ESR1 mutant population. So mutations in the estrogen receptor, that was 50% of patients in Emerald. And you can see that if patients had at least 12 months on their prior CDK4/6, so they benefited, they had 8.6 months median PFS with single agent elacestrant in the second line setting following their CDK4/6 inhibitor in the ESR1 mutant population, which is what FDA approved. Very well tolerated agents, some low-grade nausea in a minority of patients that very rarely requires antiemetic use. So very, very nice option. And these ESR1 mutant patients are endocrine therapy sensitive. This means the cancer is driven by the estrogen receptor. We just haven't heretofore had an effective inhibitor of these ESR1 mutations, and now we have this agent. Serena-2, just very quickly, camizestrant, another very promising oral SERD, 2 different dose levels, the top 2 curves versus fulvestrant, significant improvement. This is randomized phase 2. We await the phase 3 data. Just for the sake of time, I'm going to skip this. Multiple first-line trials ongoing. There's another inhibitor, a degrader of the estrogen receptor, the PROTAC ARV-471. Early data, very promising as well. Clinical benefit rates of more than a third of patients benefiting, heavily pretreated, very nice agent as well. And then the enobosarm is an AR agonist in single-arm trials in patients with AR positive nuclei, 40% of nuclei positive. We can see a nice PFS of 5.5 months, response rate of 48%. This is a very interesting agent that now is in phase 3 trials, and lasofoxifene is an oral SERM in phase 2 in CDK4/6 pretreated patients. You can see down the bottom right, it can eradicate the Y537S ESR1 mutation, whereas fulvestrant does not at all. So this is a very, very interesting agent as well. And so I'll just summarize by saying that after CDK4/6, we have a number of new agents. There'll be patients that are appropriate for elacestrant alone, ESR1 mutation, endocrine therapy sensitive disease, benefited from prior CDK4/6. That will be an option now for patients second line. PIK3CA mutation, we have alpelisib in hand. If their hemoglobin A1C is less than 6.5%, consider prophylactic use of metformin, low dose. We hope to have capivasertib at the end of the year. That'll be the first for our AKT and PTEN mutant patients. We have nothing for them. It will also be for patients whose hemoglobin A1C is too high to get alpelisib. And then, of course, we have the option of continuing on another CDK4/6. If they've been on Palbo, they could switch over to Ribo. So with that, I will stop. Thank you so much.